Hello, my name is Julian. I'm a research professor at St George's, University of London, and I'd like to welcome you to the Spotlight on Science at St George's. This is a special Spotlight on Science event because we are focusing on coronavirus, but for the first time we're doing this by video rather than the usual public engagement evenings that we've run in the past. Today's date is the 12th of March, and I am deliberately date stamping this because the events throughout the coronavirus have been moving so quickly that things change, guidelines and advice change, and some of the things that we'll talk about on the video today will have changed in days to come. So the best advice is always try to keep up to date, and at the end of the talk I'll give you some sources which we find reliable to provide advice. What we're going to do is have a quick tour of the virus, and then I'm going to bring in three colleagues. You'll meet Dr. Angela Houston, who is an infectious disease doctor at St George's, who will tell us about the clinical perspectives of the disease. We'll then meet Dr. Elisabetta Groppelli, who is a lecturer in global health, a virologist, who'll be talking to us about the impact of the virus and the importance of isolation and how to do that. And then to try and strike a sort of positive note towards the end, we're going to meet Professor Sanjeev Krishna, a professor at St George's in infection, and he'll be telling us about the prospects in the future for treatments, vaccines and new diagnostics. So by now, of course, I think everyone is very aware of the SARS coronavirus 2 outbreak, but I thought we'd all get onto the same page by sort of a brief summary of how we've got to where we are at the moment. So the virus is now called the SARS coronavirus 2, and as we all know, it's causing a global outbreak of a disease which we're now calling COVID-19. The outbreak was first identified in the city of Wuhan, which is in Hubei province in China, and at the very end of 2019, there was a cluster of patients with pneumonia who were reported, initially associated with a wholesale seafood market and animal market in the city. Only a month later, the number of cases had escalated to the point where the World Health Organization designated the disease COVID-19 as a public health emergency of international concern. And since 30th of January, more than 115 countries and territories have been affected. And as you can see on this map on the left here, the major outbreaks have been in central China, India, South Korea and Iran. And as of today, the 12th of March, there have been over 127,000 cases which have been confirmed globally. It's important to note that around the world, 4,700 people also have died, but more than 68,000 people have had the disease and recovered. We've known about coronaviruses as a family of viruses for many years. In fact, they were first discovered in the 1960s. And up until this outbreak, we knew of 6 types of coronavirus that were known to infect humans. 4 types of the coronavirus are commonly associated with very mild illnesses and often cause colds, particularly in children. Starting in 2002, we started to see 2 new varieties of coronavirus, which cause more severe disease. The first one of those is the SARS-CoV, which stands for Severe Acute Respiratory Syndrome. And later, we encountered the Middle East Respiratory Syndrome coronavirus. So where do these coronaviruses come from? Well, they're generally known as viruses of animals, that is, but they do spread to humans, and that's why they're known as zoonotic viruses. The SARS coronavirus was transmitted from bats and civet cats to humans, so the reservoir of the virus started in the animal kingdom. MERS coronavirus is predominantly a disease of camels, but then occasionally hops over into humans. The new coronavirus that we have encountered in 2019 probably originates from bats too, although that's still not quite clear. And there's also some discussion that they may have been transmitted to humans through this rather unusual animal called a pangolin. It's important to understand your enemy, of course, and many of you will have seen this picture or pictures like this in the backgrounds of the news on TV or in newspapers. These are artist impressions of coronavirus, or SARS coronavirus 2, but they do tell you some important information. So these viruses are quite small, they're round, and you see there are these projections. In fact, the reason they're called coronaviruses is because of the similarity of the appearance to the solar corona that you see during a solar eclipse. But if you take that virus and now chop it in half and look at the inside of the virus, you start to see a little bit more of the structure. And this diagram here shows you more of the detail. Now, I'm not going to go into great detail about this, but the key elements of the virus are the nucleic acid, the RNA, which is inside the virus, and that's represented by this squiggly line here. And then that's encapsulated in an envelope, and this is made up of proteins. But the most important protein in that envelope are these sort of mushroom-like projections, which are these things on the picture. And these we call the spike protein. And this turns out to be quite important. Now, understanding the nature of the virus is really important for us because it tells us a lot about how the virus actually works. So, for example, we know that viruses can have different types of nucleic acid inside them, but viruses that have RNA, like the SARS coronavirus 2, tend to like to mutate more than others. And so we know that this is a virus that will probably change over time. The other important thing is the spike protein that I mentioned earlier. And it's this protein which allows the virus to actually attach to the human cell that it's going to infect. And that's shown on this picture here, where you can see a number of coronaviruses attaching to the green thing, which is the human cell. In fact, we know that the spike proteins have to find and identify a particular protein on that cell surface to attach to. And that's why they have some sort of specificity for particular cells in our body. That protein on our cells is called the angiotensin converting enzyme 2. Now, this is a slightly complicated slide telling you the life cycle of the virus, and I'm not going to go through it in great detail. But the point I want to make by showing this slide is that by understanding the mechanism of infection, how the virus actually gets into the human cell and what it does inside the cell and how it replicates is actually really important in how we design and develop new treatments and eventual vaccines. In fact, we know quite a lot about how coronaviruses infect cells from the other types of coronaviruses I described earlier. And so here I'm showing you the coronavirus outside of the cell, and here is the spike protein attaching to that angiotensin converting enzyme protein on the human cell surface. Everything in blue here represents inside the cell. And this diagram shows what happens to the virus when it gets inside the cell. You can see that the virus opens up and releases its RNA, and then there's some fairly complicated replication going on here, which eventually forms the new viruses, and they are released back out of the cell and on to infect the next cell or indeed the next person. And it's by understanding these particular processes that in other diseases has allowed us to find interventions. So, for example, can we interfere with how the virus might bind to the ACE2 protein here? Can we interfere with how the virus might open up and release its nucleic acid at this stage? Or indeed, can we do anything to block these processes here which allow the formation of new virus particles? So I think that's probably enough of a sort of basic virology lesson for now, and I think we should now move on to sort of the more practical aspects of SARS coronavirus 2 infection. And in fact, I'd like to move to my colleague, Dr. Angela Houston, who's going to tell us about some of the clinical manifestations of the disease. So I'd like to turn now to Dr. Angela Houston, who's a consultant in infectious diseases at St George's University Hospitals Trust. And Angela, I know you've been in the thick of it. But can I start by asking you, Is it the case that everyone who catches this disease will have a serious illness?
Not at all. So the first thing to say is this is a new virus, so we don't know exactly how it's going to behave. Mm-hmm. We know we've got a population that doesn't have immunity to it, and that's why we're worried. Looking at the people that have had this virus in China and Italy and around the world, at least 85% of people will have a very mild illness. So most of us, particularly young people, will have a mild illness. They might have a flu-like symptoms for a day or two, maybe a cough or a cold, but they should be well and they should be able to stay at home and self-isolate and not come anywhere near hospital. Okay. Obviously, what we worry about is that 15% of people might have a severe infection. So that means that they will need to come into hospital and they might need oxygen or certainly assessment. And of those people that come into hospital, a number of them will have a bilateral, that's a pneumonia on both sides of their chest that's severe enough that they might need to have critical care help. And that's why we've got so worried about this infection.
So, which are the groups that you're most worried about?
So the people who are elderly, or I should say people who are over the age of 65, so not even elderly, but older people who have got long-term medical problems, which means that their immune system is not so strong. So people who are diabetic, or people who are on drugs for cancer, or people who are on steroids for whatever condition, they might be more likely to pick this up. And if they pick this kind of infection up, they might be more likely to get a severe infection. So it doesn't mean they will, but obviously their risk factors mean that they might be more likely to get severe infection.
And can you tell us what are the early symptoms that we should be looking out for?
Well, as I said, a lot of people have a very mild infection, so they might just have a fever, headache, sort of flu-like symptoms, aches and pains, a cough or a cold, bit of shortness of breath. So, most of the time this is going to be like flu, like a bad flu for most people. A lot of people are recovering within a few days, but there are those people that go on to have symptoms that continue and they get more short of breath. And obviously when you get more short of breath, that's when you need to be assessed and we need to see you in hospital.
And I know a number of people are being advised to come in for testing. Can you tell us what that involves?
So at the moment, if people have symptoms, they're actually being advised to phone NHS 111, who will assess the patients on the telephone from home, and they're being advised to self-isolate at home. That means staying in your own house, keeping away from other people to try and prevent the spread of this virus. If somebody is short of breath, then obviously they need an assessment by a medical practitioner. So NHS 111 can triage you, make that decision, and people can come in to A&E, but we like to know that you're coming in so that we can make sure people are seen in the safest part of the A&E department, and assessed by a doctor who's got a surgical face mask and gloves and an apron on, just to make sure we're trying to prevent the spread of this virus.
Okay. And if you were unlucky enough to be severely infected by an infection, what would the visit to the hospital sort of look like?
So I guess when you come into hospital, you'll be assessed by a doctor who will be wearing a face mask, an apron and gloves, so don't worry about that. That's what we're all wearing because we're trying to prevent infection spreading to our healthcare professionals. It's really important to try and prevent that so that we don't spread it in hospitals and we stay healthy. So a doctor or a nurse will assess you. If you need admission to hospital, you will be admitted and you will be given the best care that you'd be given any time you're admitted to hospital. So that might be that you need oxygen, it might be that you need antibiotics, you might get a chest x-ray and blood tests. So it's every single person will be different. Some people will have more severe infections, some people will have a mild infection.
Are we not swabbing people anymore in their cars?
So if patients in the community fit the Public Health England case definition, then and NHS 111 have triaged you and think that you need swabbing, then there are different routes that you can be swabbed. So this is patients in the community. So if people have their own transport, they might be directed to their local coronavirus assessment area, where ideally patients could be swabbed in their cars. So that means we can see lots more patients safely, or they will be assessed in the pod. Some patients, particularly in London, don't have their own transport because to be assessed in a hospital, you have to be able to get here with your own transport. So if people don't have their own transport, then we have community providers that are going to people's houses and doing swabs in the house. So at the moment there is community swabbing going on. It may be that in the future the Chief Medical Officer for the UK says that we no longer want to swab people in the community and just focus our resources on patients who are unwell in hospital. So that is a possibility.
Well, thank you very much, and thank you also for you and your team's hard work in this area at the moment.
It's a pleasure.
I'm going to turn now to Dr. Elisabetta Groppelli, who is a lecturer in global health at St George's. And Elisabetta, I know you've been following this viral outbreak quite carefully over the months. I want to start off by really asking you, what is special about this coronavirus and the diseases that it causes?
I think the most important thing about it is that it's novel. It was so novel that we didn't have a name for it. We didn't know what it looked like and also what diseases it caused. And obviously it's so novel that we didn't have a name for it. So at some point we just called it the novel coronavirus. Now there is a name. The scientific name is SARS-CoV-2. And there is a name also specifically for the disease, which is called COVID-19. And in terms of what is there is special about this virus is because it's not new just to science, but it's also new to humans. It's come from animals, from an animal reservoir. And it was the first time, likely, that this happened. So it means that our bodies have never seen it. And therefore, this makes us, well, quite vulnerable.
We've heard similar things about another virus, the flu virus, that also comes from animals and often has this major shift. What's the difference then between, why should we think about coronavirus a bit differently than flu virus?
The thing is that, as I said, this coronavirus is totally new. In terms of flu, we have been exposed to flu for many years. And of course, as you say, it keeps shifting from one animal to another one. But there is some cross-reactivity of, so it means that our body will remember that we have infected before. It might not be the best response in terms of immunity, but this gives us some protection. So again, this is something quite different compared to being faced for the first time with a virus that we've never seen.
Right.
There are very detailed scientific explanations. Also, they are not the same viruses. They do not belong to the same family. They do have something in common, which is actually looking. And I'll try to use something that I like: Easter eggs. So this type of viruses are made of chocolate shell. But they also have an outer layer. And this outer layer is very vulnerable to soap, for example, or to any of the chemicals that we might use in household cleaning. So in that sense, the viruses, although they have differences, especially at the genetic level, they are vulnerable to the same kind of measures that we might want to apply.
Yeah. And in terms of spreading the virus between people, so I understand that viruses are more susceptible to just being on a surface for a prolonged period of time, just dying on the surface. Why is that?
So again, this virus is because they have this envelope, this wrapping, which is made of lipids, and also they have a little bit like marshmallows, sitting on the outside. Those can dry out, can become not the same as a fluffy marshmallow, and therefore they don't work as well. And these are integral part of the virus that is needed for the virus to get into cells. So if they are disrupted, excellent, we don't have an infection. And this, again, is a positive thing about it because it gives us in directions about where to go. There are some other viruses that do not have this wrapping and the marshmallows. And actually those ones are much more difficult to kill, for example, with soap. And an example of this virus is the norovirus, which we might be familiar because of the nastiness of the...
causes other outbreaks, doesn't it? Yes.
And it does cause this outbreak, yes.
Okay. Now, one of the critical recommendations for people developing symptoms, we heard about it from Dr. Houston earlier on, is self-isolation. And I wonder if you could just tell us a little bit more about what that actually means and what it looks like in practice.
I think there are different levels and different ways in which a self-isolation can manifest itself. But when it comes to the coronavirus, this particular one, there is its particular relevance to because many people, 80% of the cases, are actually mildly symptomatic, which is a really good thing because they do not require hospital care. However, they can still transmit the virus. So isolation, self-isolation for these individuals means pretty much stay at home, isolate yourself as much as possible, that is in a way that is compatible with your lifestyle, compatible with the people you live with, but is also in an effective way. Because, as I said, the virus can transmit from person to person, and the virus can remain on surfaces for at least hours. So this means try to limit where you are within a room.
Yep.
And maybe choose which room it is. If you maybe just want to be in your bedroom and watch Netflix, that's a good idea. If you are the one who's going to be working all day, possibly that's a good idea to pick that room.
Other channels are available, of course.
Oh yes, we are going to be saying that. Do apologise. I might have also revealed something about myself.
Tell me about this thing about living with other people, though, because, of course, you're not just isolating yourself from the world. You've got to think about your family or whoever cohabits with you.
Yes, and it is, again, limiting yourself to a room, but of course you might not have the possibility, for example, to share, bathroom facilities, or not share those. So the recommendation is, again, be sensible. For example, let other people, the uninfected or the unsuspected ones, to use those facilities first, and then you use them, and then you clean them. Because, again, the virus can be transmitted via surfaces and can live on those, especially those in the bathroom when there is a high humidity and a high temperature, which is quite good when you're having a shower, but it's also good for this virus to last a little bit longer. And also when it comes to shared spaces like the kitchen, self-isolation means try not to go to the kitchen, try not to handle food, get a takeout or have someone else prepare it for you. And again, unfortunately, I know it's fantastic, and I am Italian. I love sharing dinner with people and having lots of people over dinner. But self-isolation means that it's much safer if you eat by yourself.
Okay. So perhaps my last question really is around, what about all these people who have managed to get infected and have managed to survive and recover? What do we know about the long-term protection against a second infection?
I think it's right now we can only know what's 2-3 months old, and then in science terms that is not long. Some studies that I have looked not at the patients, but I've looked at their blood samples that contains the antibodies. It would support that these patients have developed antibodies that would likely protect them from an infection, which is a really good starting point. However, it would be crucial to repeat this test on a regular basis and for years as well, because it will be important to see how long this immunity lasts. Because as many people, if the more people get infected by recover, it means that us as a population become stronger because the virus cannot come back.
Actually, I did have one more question, and that is, how likely do you think, once we're over this this episode, that we will have to face another attack of coronavirus?
I think as far as coronavirus is, the fact that it's happened before is likely that is going to happen again. But this is also true for many viruses. And so when it comes to pandemics, but also when it comes to outbreaks, or when it comes to even epidemics, we need to familiarize ourselves with the fact that it's a matter of when, not if.
Elisabetta, thank you very much indeed.
That's a pleasure.
Okay, so I'd like now to introduce Professor Sanjeev Krishna, who is a professor of molecular parasitology and medicine at St George's, and also one of our consultants in infectious diseases. So Sanjeev, we've heard about the virus, and we've heard about the disease, and we've heard about the outbreak. And I'd like to come to you now for a little bit of hope, really, for the future. And we know that research has been targeted as one of the overarching priorities for our response to the coronavirus. So can you tell me what areas do you think research needs to be targeted?
Of course. Well, for dealing with any infections, usually we look at targeting research in three broad areas. One of these, and the first of these, is really diagnosing the disease better. Mm-hmm. The second area is being able to treat it. And then, equally, if not most importantly, right at the end, of course, you want to be able to prevent the disease. And to do that, you need to be able to have things that are effective, like vaccines. Yep. So those are the broad areas of research that are being developed for coronavirus now, just as for so many other infections.
So can you give us some idea of, for example, the treatments that are being explored at the moment?
Yes, of course. The treatment side and the vaccine side will always take longer than diagnostics. I think that's the first thing to say. In places where the virus has first started, in Hubei province, for example, in Wuhan, in China, they have been implementing extremely quickly very large numbers of trials looking at possible treatments. Now, usually it takes many years to come to really strong results about whether a drug A will work against a disease B and so on. But what they've been doing is to roll out trials so that we've got literally dozens, if not hundreds of clinical trials taking place.
And I guess that's sort of building on our experience from Ebola in Africa.
It certainly is. There's a lot of lessons, and I think very important lessons, that have been learned about how to do trials like this on the fly, if you like, when the disease is just breaking out. Because there are ethical questions, there are questions about how you support people appropriately during these trials and so on. But to answer your question as to how long it might be before we get results, it really depends on what the not the quality, but the robustness of the results would be. So if you wanted early results, they can come, fairly quickly in the space of weeks or months. But if you wanted results that in the end may change practice globally, it may take a bit longer. So we're looking at months rather than weeks.
And how long do you think it might be before we get a vaccine?
That really is a very important question, which most people are asking. We're at a relatively early stage in vaccine development. And I think that the earliest we would be looking at for preliminary results from something would probably be in the time period of about a year.
Okay, all right. Now, the third thing that you mentioned was the development of new diagnostics. And
yes.
Why would that be important when we already have some diagnostics that are being used widely?
It's very interesting because let's just step back a second and think about diagnostics in general. If we don't have a vaccine and if we don't have a treatment, the only way you can really have an impact on this type of infection is to stop it being passed on. And in order to do that, what we call breaking the chain of transmission, what you need to do is to be able to recognize as accurately and quickly as possible who might have the infection, so that you can bring in all these measures that we're all now hearing about, and some of us are also getting used to implementing in one form or another.
Yeah.
Now, the current ways that we diagnose take time, and they are relatively clumsy in the sense that you have to take a test, whether it's a swab or whether it's a blood test, usually a swab, and you send it off to a central lab, and it takes maybe 2, 3, 4 days sometimes at the moment for the results to come back. And that's an awful long time for somebody to wait. And the idea is to speed up that process so that the whole decision-making pathway to contain the infection, to isolate individuals, self-isolate, can happen as soon as it is practicable to do.
All geared towards understanding that you might have the disease much earlier than otherwise, and you can do much more if you have diagnosed earlier.
Once you've got the diagnosis, and of course, you're in a very good position, or a better position, to even monitor what the infection is doing. Even if you don't have to see the person every day, you can actually contact them, and you can monitor to see how their disease is developing. So that means you're in a better position to anticipate any complications that might arise.
And I understand some of those diagnostics are using very, very modern technologies, so far away from swabs and cultures that you're talking about.
You're talking about perhaps some of the molecular tests that are being used. Yes, these tests are being widely developed now. I mean, there are also, just as there are with the treatment trials, there are tens, if not hundreds, of tests that are being used out there, or at least being advertised out there. I think, as with all of these types of advances, we need to be evaluating them very carefully to look and see how accurate they are, to see how easy they are to use, to see if they're affordable, and to see how how valuable they are in the overall healthcare pathway.
And one last question, if I may. I mean, how important is it when you're exploring these new treatments, vaccines, diagnostics, that they are affordable for a global population as opposed to one, for example, in the UK?
I think that's a question that's really close to my own heart. When we look at Ebola and the outbreak that was there in 2015, for example, what we know is that diseases that were common in places in Africa, like malaria, started to get left behind. So there were more people sometimes dying of malaria, which could have been treated, diagnosed and treated, than from Ebola, for example. And our worry, our concern, is well beyond our own borders here. So as COVID-19 spreads, the risk is that other diseases that are diagnosable, that are treatable, start to get left behind. And suddenly we end up with a worse case where patients are dying of something that's treatable, because we've taken the eye off that ball.
Obviously, Sanjeev, all these interventions have to work and they have to be accurate. What are the other sort of key considerations you think we have to be thinking about when we develop them?
Well, this infection, COVID-19, doesn't respect boundaries. It's already become a huge global threat. And for us to be able to intervene effectively, and for the moment we're talking about diagnostics, but that could apply equally to therapeutics or vaccines, these interventions have to be affordable by the poorest people. And so we must always be aiming for not just scientifically the right answers, but socially the usable answers as well.
Yeah.
And that has to come down to cost.
Thank you. Well, I'd like to thank all my colleagues for helping with this video. I'd also like to thank everyone at St George's who's contributed to putting this video together. As I said at the start, this is a rapidly moving field, and remaining up to date is really important. We all rely on the internet these days, and there are so many websites. So I think it's important that we use trusted websites, and I've indicated the 4 that we would recommend. The NHS will provide important information for patients, Public Health England, and the government, of course. And for a more global perspective, have a look at the World Health Organization website, as well as the Johns Hopkins coronavirus tracker, which is the source of the map that I showed right at the start, showing the outbreak across the world, and that's updated on a daily basis. Well, thank you very much for joining us. I hope we have provided some information that is useful to you. Thank you.